It is nice to see you again and welcome everyone to beautiful Amsterdam. My name is Anne van der Made. I am an orthopedic resident and researcher focusing on hamstring tendon injury at the University of Amsterdam. And today I wanted to discuss the potential hamstring injury blind spot, the proximal hamstring tendon avulsion, as well as touch a bit on decision making once a diagnosis has been established. So first off, what I mean with a blind spot is that I think that these severe hamstring injuries are easily missed. And I want to discuss two of the clues that could point in that direction. First off, this is a graph of the number of publications cumulative over the years. And we can see that the number of publications on proximal hamstring tendon injuries has steadily risen over the past decades. Now let's add in this MRI. That was the first MRI of a human being ever made in the late 70s. And now, of course, we can see that the rise in publications has only started at that point. Now, this could naturally be a coincidence, but it could also be that we only started recognizing these injuries as soon as we started seeing them on imaging. Another clue came from our ongoing prospective series on outcome of treatment for proximal hamstring tendon avulsions, and we noted that the proportion of patients that were clinicians in this study was way higher than the proportion of clinicians in the Dutch adult population, which is about 0.5%, but in our study it was 1 in 5 patients. So at first we jokingly concluded that a severe hamstring injury might be an occupational hazard, but that's not really logical. So we quickly realized that it was more likely a selection because clinicians know their way around healthcare systems, know their anatomy and so on, and may therefore have a better chance at an accurate and timely diagnosis. We also note that, which you can see in the graph in the middle, that a diagnostic delay was not present in any of the clinicians, either medical doctor or physiotherapist, but was present in a substantial proportion of the non-clinicians that we had included so far. So it could very well be that these clues point in the direction of misdiagnosis. We published this as an editorial in the British Journal of Sports Medicine, where you got quite a few responses of fellow clinicians that had the same experience in their practice. So it's important to maintain a low index of suspicion for these injuries, especially considering that the impact of such an injury is major, and you don't want to miss this to be able to treat your patients the right way as soon as possible. So let's go back to basics first, the anatomy. This is a posterior view of a right buttock area with 5 indicating the ischial tuberosity. And we can see that there's a tendon attaching onto it, which is the conjoint tendon of the biceps femoris, the long head, and the semitendinosus, which have a common tendon, as I mentioned. If we reflect this tendon, we can clearly see that there's another one there, which is the proximal semimembranosus tendon. So bear in mind, there are 3 hamstrings attaching proximally by means of 2 attachments. So we can see where the injury happens on this coronal MRI image. Here there's a schematic view of muscle and tendon that attaches onto the gray area, which is the ischial tuberosity, and the proximal hamstring tendon avulsions occur at the interface of bone and tendon. As seen on the right, where we can clearly see that there is a discontinuity between the tendons, which now have a wavy appearance lying in hematoma, and the bone itself. So on to recognizing this injury in your practice. So the injury mechanism is a forced hip flexion combined with knee extension, which you can see happen now in the video. You can see that the gentleman that's throwing the ball now slides forward with the left leg, extending the knee and his weight forcing him down into hip flexion. These patients will often report severe pain with difficulty sitting and a stiff walking pattern, as well as a popping or tearing sensation and severe function loss. If these patients present acutely, there is often within several days extensive bruising over the posterior thigh, as well as palpation pain over the ischial tuberosity, with a palpable defect upon resisted knee flexion just distal to that, with naturally decrease in range of motion as well as strength. However, if we think that these injuries are easily missed, there must be some pitfalls that make us think that it is just a regular hamstring injury, while in fact there still may very well be a proximal hamstring tendon avulsion. And these include the subsiding and migrating bruising. Here we can see a patient after 2 days, 7 days, and 10 days. So you can imagine that if a patient presents after, say, 2 weeks, the hematoma has either fully subsided or has migrated distally towards the back of the knee. So maybe you think there's a knee injury or distal hamstring injury, but bear in mind it could be a proximal hamstring tendon avulsion. Also, in addition to the injury mechanism that I just described, we have had patients with an abduction trauma rather than a hip flexion trauma. And while you might think that these patients will have an adductor injury, adductor, which in fact they had, low grade, they also had a proximal hamstring tendon avulsion, so still a possibility there. We also discussed the range of motion as well as strength. Bear in mind that if a patient presents after some time, so not in the acute setting, range of motion may actually be increased due to the loss of tension on the hamstring unit. And also patients might be able to flex the knee against gravity or even against resistance because there are additional muscles that can facilitate this movement. For example, think short ad of the biceps femoris or gastroc muscles. So if you have any doubt regarding diagnosis, something doesn't add up, or you might think about this injury, make an MRI, make sure that you can rule out this injury, or if you cannot rule it out, if the diagnosis is confirmed, so that you can move to proper decision making. Because for this type of injury, you can either go with non-operative or operative treatment, and ideally we want to rely on literature. But unfortunately, this is where we encounter a problem because the literature is limited by methodological limitations. The body of literature is mainly retrospective, mainly based on case series, and we only have a handful of non-operatively treated patients to assess their outcome. So then a comparison of outcome to guide us for treatment decision making cannot be made. And so with that lack of comparison, we were curious to see how experts manage their decision-making in clinical practice. So we did a worldwide survey, including over 400 experienced sports medicine physicians and surgeons that dealt with this injury almost on a daily basis. And so I will go over this the study very briefly, and this is the top 3 indications used in clinical practice that help clinicians make a choice for operative repair. First one being tendons involved. If both the conjoint tendon and the semimembranosus tendon were avulsed or ruptured, then clinicians would generally choose surgical repair. If these tendons were retracted more than 2 centimeters from the ischiotuberosity, as well as if patients were unable to perform activities of daily life or participate in sports. And needless to say, but I've still highlighted it here, elite athletes that wanted to return to sports were generally operated on. So from me, the take home, or in this time maybe stay home message will be beware of the blind spot. Proximal hamstring tendon avulsion has likely seen you more often than you have seen it. Maintain a low index of suspicion. Beware of the pitfalls and make an MRI when in doubt. And once a diagnosis has been made, decision-making based on expert opinion can be guided by the following. Consider surgical consultation in cases of elite athletes or retracted avulsion of both attachments with the inability to participate in activities of daily living and sports. So that is all from me for now. From my side, it was a pleasure. I hope you found it informative. And then we will now go back to the place where the sun always shines. Doha, back to you, Rod.